Hello, my name is Rachel Rommel, and this is a quality improvement case study on an insulin overdose. Case overview. After an intensive shift, which the senior registered nurse anesthetist resident has been working since 0630, a call comes for help for an emergency surgery on an ischemic bowel at 0300 the next night. In the middle of the surgery, the senior RNA resident accidentally administers an incorrect dose of high-concentration insulin, 10 cc's instead of 10 units, resulting in the administration of 1,000 units of insulin. So what went wrong in this case study? A lack of culture of safety. If the hospital has a culture of safety, there will be policies and procedures to assure the right administration at the right time in the right way. In this instance, a double sign-off on the draw of the insulin should have been policy. There was also the unfortunate scheduling. The senior RNA should not have been working on that surgery with a tired brain and body. Lack of second confirmation. Often in surgery, to assure that the right procedure is done, a professional will announce what they are doing and ask for a confirmation, thereby double-checking your work safely. How can these issues be resolved? A policy of double-check. Using a double-check system for all insulin administration and calling the dosage out loud to assure the correct dosage. Pharmacy assistance. Pharmacists could supply less concentrated insulin in the surgery unit or have been present at the surgery to confirm dosages. Procedure timeouts. Using a timeout, such as in surgery, to confirm the administration details out loud to remove uncertainty and give an opportunity to identify mistakes. Team members' responsibilities. The surgery nurse is responsible with drug administration, surgery assistance. They could have initiated a double check on drug dosage. The surgeon is responsible for assuring proper procedure and responsible for performing the procedure. He could have initiated a timeout. The anesthetist is responsible with drug administration and patient anesthesia. They could have asked for a double check on dosage. The pharmacist is responsible for supplying drugs and prepares drugs for surgery use. They could have been present to be a double check or initiated a timeout. My proposed solution is twofold: policy in place for patient safety and creating a culture of safety. Management of the healthcare unit should include the policy of using additional steps that have shown to improve patient safety. One such policy should be the double check for any harmful and potentially fatal drug. At the hospital I work at, insulin drips and surgery administration of insulin requires 2 nurses or pharmacists to verify dosage. This is a method that can assure the correct dosage administration. The effectiveness of a systematic approach to surgical safety has been documented with the use of safety checklists, standardization, and emergency protocols. A culture of safety means that the workplace environment is one where a reporter of an incident or mistake can be made without fear of reprisal. Root cause analysis can be a way to find how an unsafe situation came about. It can point to weak spots within the system that have the ability to endanger patients. This should also include the staffing management to assure good and healthy working hours. Barriers to this change. The thought process that this is the way it's always been. A lack of education of systems of safety. A lack of oversight of safety systems. Lack of staff to fill critical positions. Overwork in busy conditions, hierarchical traditional roles, embarrassment with asking for help, poor communication skills, lack of training with dosages, or lack of interprofessional teamwork. It's important to have a culture of safety so that employees can feel free to offer solutions and come forward with concerns without fear of reprisal. Here is a list of my references. Thank you very much for listening to my presentation.